All right. So thank you for having me on board for this meeting, allowing me to present about our experience we have made in the past 6, 7, 8 months in the transition of our high volume, high intensity robotic urology program into a sort of more complicated program, including single port surgery. Um, I would first like to introduce our program a little bit, as well as our concept in robot-assisted surgery in general, because that's important to understand how to implement a new robot-assisted surgery platform like the one we have been using now for several weeks. We are pioneers of minimal invasive surgery. Urologists are the ones who have the most experience, I think, in minimal invasive surgery in general. We started performing these surgeries early on, and we have transitioned, I believe, exceptionally well into more modern and more sophisticated technologies. So we use minimally invasive surgery and mainly robotics basically across the board in all surgical and neurological indications, from benign indications such as BPH to cancerous indications such as prostate cancer or urothelial cancer. So it's a very common use for us. And we've been in that field already for quite some time. I myself started robotic surgery in the early 2000s. So in 2001, we performed the first reconstructive procedures of the upper tract, as well as partial nephrectomy. So we do have a long-standing experience with robotic surgery, and we have kind of like transitioned from the very simple old basic platform into really the very advanced new platforms that we've been using now in the past few years. As I said, we started in 2000, and the first real game changer that came in was the S platform in 2006, followed by the SI platform, which was basically the first sort of ready-to-use platform, which has significantly advanced robotic surgery in general. However, mainly in urology, and this is the reason why, is because the Da Vinci SI system was very bulky. It was very difficult to use for general surgeons, and it was very difficult to use it in multiple quadrants. And that's why XI came into the market more than 10 years ago with much more versatile arms. You require less space. You could move around in several quadrants, which eventually led to a more wider adoption of robotic surgery, not only in urology and in pelvic surgery, but more importantly, also in general surgery. As you all know, there are many new systems out there, but I think right now still most of us rely on the intuitive platform for our robotic surgery journey. And when your robotic work is growing, obviously you need a new system and you need to expand your capacities on the robot. And it's not only the competitors that are improving their systems, it's also intuitive itself, with the DV5 platform being the last and most modern multiport platform available in the market. And when you are expanding your service, it's a question that you have to ask yourself: do you want to use another multiport system, or do you want to embark on something totally different, namely the single port or SP system, which is from its principle something totally different, because it's suitable for the use in very narrow spaces. It allows multi-quadrant access in wider spaces, such as in general surgery, and it is perfect for multidisciplinary use, from ENT to transanal to urology work. So it offers a very wide range of fields that you could use the robot for. In Germany, just like in Poland, I believe robotic systems have now sort of flooded the country. There are many systems now all over the place. Most people are well aware of how to use a robot and also for which indications. So it's an important question. If you change your attitude towards minimal invasive single port surgery, on how to sort of find your space into in a widely saturated market with robotic systems basically around every corner. So let me just quickly introduce our center. So when we were at the turning point, so at the end of 2024, beginning 2025, we had about 65 beds for urology. We were using 2 XI robots, one 100%, the other one about 30%. And we had been doing about 7,000 urology procedures in total, with a staff of 25 people in urology, with an all-in approach for robot-assisted surgery. So it's basically every indication is considered eligible for robot-assisted surgery, and we basically don't do any robotic or any open surgery anymore. In our specific healthcare system, we are facing challenges, just like probably every one of us does, and we suffer mainly a disproportion between revenue, which we are receiving for certain procedures, and cost at the same time. So the only way for us as an independent institution to remain viable is to reduce our cost. And this is something very difficult, because we are facing some fixed cost, fixed expenses, as well as staff expenses, which we literally cannot change easily. And the only thing we could really change is how we use our infrastructure in the most efficient and most elegant way, in order to escape these constraints that we are just having because of the healthcare system. So I would say our approach in our institution is unique in a way that we are quite pragmatic. We decide things and then we start doing them, and then we revisit what we have been doing. We check what we did, and then we act again. And it's exactly the same as what we did here when we started with a new system. We started and then reassessed efficacy, quality, and obviously also cost along the way, in order to be able to implement a completely new platform into a very well organized setting. Our team is very friendly. They are all very interested in the advancement of minimal invasive surgery, from multi-port platforms to single-port platforms to endoscopy to spine navigated surgery. So all of them are very tech, how should I say, interested in tech. So they love to develop something new. So it was easy to create some enthusiasm in our nursing and also in our doctor staff. So this is what we did 2 years ago. So we were always considered a high volume center with a very high intensity. So it was typical for us to do between 5 and 8 surgeries per day per robot, yielding about 1,400 procedures in a year. It was mainly consisting of urology, plus a relatively small general surgery robotic program. And robotic prostatectomy was considered the financially most attractive procedure. We've always been looking at our data very intensely. So in order to understand what you're doing, you need to understand your metrics. So your operative time, your turnover times, case complexity, and so forth, in order to understand what you do. And this is especially important when you change something. When you bring in a new system, when you bring in a new surgeon, when you bring in new anesthesia protocols, you have to measure your metrics with the very same technique, especially when you do something new. We have developed a very stringent and streamlined perioperative protocol, including a very tight collaboration between surgeon and anesthetist. We have incorporated regional anesthesia concepts in order to reduce pain and also in order to facilitate anesthesia, especially during the final phase of anesthesia, which gives you opportunity to have your changing times very short. We use ERAS protocols, obviously, and we try to discharge our patients early. So if you have this already, then it's quite difficult to improve that. At least that's what we thought. We have already had a very efficacious pathway with an induction room, separate OR unit, and an exit and cleaning room in order to have a very interactive workflow to keep things fast and simple. We had simplified our anesthesia processes with ultrasound guided blocks, which have been very well established. We use it also in our SP setting. We have implemented a very, very stringent and a very reproducible process when it comes to the setup in terms of instruments and trays, so very simplified trays. And we also made use of this simplification when we have now transitioned into SP surgery. Likewise, the use of disposable materials, we have really reduced the use of disposable materials over the years, again, to save cost and also to keep things simple for the surgical staff. And it's quite fundamental to understand how surgery works. Surgery is a team game, so you have to work together from the anesthesia standpoint to the surgeon standpoint to the nursing standpoint, and all that leads to reduction of cost, reduction of unnecessary OR time, and also still allows for a very structured modular robot-assisted surgery training. And the impact on staff, as I already mentioned, is enormous. If you keep your things the way they should be, you will find people to work for you, and they will be interested in implementing something new. And over the years, we had already had a significant impact on turnover times, with our turnover times now being between cases around 35 minutes. And I can tell you with the SP platform, we're actually even quicker because the setup is easier. So the question that came up for us last year was, should we add another new generation multiport system, maybe another company to have an impact on pricing, or should we go for an SP system? And the choice was easy for us because we chose an SP system because we wanted to expand the robotic use in general towards colorectal, endocrine, surgeon, and breast cancer. And we also wanted to close the last gaps in urology while we are improving patient safety and patient comfort. There are many challenges, mainly the learning curve. Outcome quality, do we still have the same outcome quality from the very beginning? Do we get the same volume? Do we get the same efficacy? How to teach SP in a team that is already quite efficacious? And how to reprocess the instrument. So it was quite a challenge, or many challenges when we started. And I can now tell you that we have done more than 300 cases with the SP platform, more than 120 already in this year. We have basically used it throughout the whole field of urology, just like we used to do it with the multiport system, but we chose different patients. And it's an ideal setting for patients who had previous procedures in their abdomens, where you need to clear adhesions if you do a cystectomy, for example, or you choose an alternative access, just like an extraperitoneal approach for the prostate or retroperitoneal approach for the kidney, or even better, retroperitoneal approach for nephroureterectomy or for RPL&D. So you find yourself in totally different fields with a much smaller space and definitely better outcomes for our patients. And we have made the observation that SP is actually the perfect tool, not for the easy procedures, but much better for the complicated ones, such as patients with some abnormalities in their anatomy. The last gaps that we wanted to close for the standard indications are for patients, with, as I said, with hostile abdomen, patients with poor lung function who you cannot put in Trendelenburg position, patients with cardiac issues that also have problems potentially with deep Trendelenburg, patients who might have some considerations for cosmetic outcomes, such as young ladies with UPJ obstruction. And also, there is a significant unmet need in very slim patients for robot-assisted multiport surgery, because you simply have problems to place your ports wide enough from each other to have a perfect working setup with a multiport platform. And also, we have expanded our program towards nipple-sparing mastectomy. So we've done a handful of cases with nipple-sparing mastectomy, which I must say is a very elegant approach too. We started our transoral thyroidectomy program with a submental approach, again for scarless approach to the thyroid. Also, transanal approaches for deep-sitting rectal cancer, fistula repair. So we have already had some very interesting cases, and the effect for our institution is quite clear when we look at what we have achieved with the SP. And our reality is that we have actually mitigated cost, which we were quite afraid of. The outcome quality is definitely much better. We had a very short learning curve. We now have several surgeons trained on the SP. We have significantly increased the volume. We have increased our efficacy, which was already quite high. It was easier to teach people who already have experience on the multiport system. And we have also created a facilitated process for the reprocessing of the flexible instruments, which is also very interesting. This is where we stand now. So we have increased our volume per robot to up to 9 cases in a day, either on SP or XI. We do now use 2 SP and 2 XI systems. We are increasing our volume to about 2,200 to 2,500 procedures per year, and we've expanded the robotic program away from urology into colorectal, hernia, endocrine, and we have also started a breast cancer program, which I believe is quite nice. And this is just to show you that you can also do very nice hit lists using the SP with multiple cases in one room. This is just 6 cases in one single room using the SP platform. So SP in a high volume robot-assisted center, in my opinion, is 100% added value. It can be successful not only from a patient standpoint, but also from a financial standpoint. And new concepts clearly open up new potentials for our patients. And I hope I could whet your appetite a little bit for the SP platform. You're all invited to come to our center to witness how we have progressed with this new platform and ventured into completely new fields, not only in neurology, but also in other indications. And with that, I would like to thank you, and I hope you enjoy the rest of your event. Thank you very much.